There's been stigma around cancer, around neurodegenerative disease in the past. And we've moved to talking about it more, making diagnoses, coming up with therapies, but not ignoring these issues. And I think that should be the same here. So that's kind of a hope for the future. I think if we talked more openly about these symptoms and how they are treatable, even if we can't get rid of them entirely, and how we can still have productive lives and happy lives in the setting of some of these symptoms, I think that would go a long way. I'm less optimistic that technology will solve this problem. I think it's things like policy and changing how we play the sport that will be the best. Jesse Mez. I'm an associate professor of neurology at Boston University.
What issues are very important to you as a researcher?
So I'm trained as a neurologist. I specialize in aging and dementia. I spend a lot of my time in the research space, but it's very much in service to the clinical care. So I'm really interested in how risk factors affect risk for long-term neurodegenerative outcomes, particularly head trauma, repetitive head impacts, as well as genetics.
Thank you for that. I think you really laid the background really for for this conversation. The first time that I heard about these kind of impact on sport players has to do with football. At what point did you start thinking about looking at what is happening in ice hockey to what really attracted you to actually study this disease, this condition, or this category of sports players?
Right. So since about 2009, Boston University has had a brain bank, what we call the Unite Brain Bank. And participants or brain donors have to have exposure to repetitive head impacts or other types of brain trauma in order to be eligible for this brain bank. And at this point, there are about 1,600 brain donors who have donated. The vast majority of them are American football players, but it also includes ice hockey players, rugby players, soccer players, folks who served in the military. And we did this type of analysis initially in American football players, and we saw this really strong dose-response relationship between years of play and risk for CTE. It was only recently that our size of hockey players was large enough to do a similar type of analysis. But when we spoke with family members of the deceased, and when we looked at their pathology, even before we had sample sizes large enough to show these relationships statistically, we saw that this disease was not uncommon among the ice hockey players, at least among those who donated their brain.
Okay, that's interesting. For those that do not know what CTE is, the full meaning of CTE is chronic traumatic encephalopathy. So, can you give a quick background on that condition, what it is?
Sure. So CTE is a neurodegenerative disease, not unlike Alzheimer's disease. It is defined neuropathologically, meaning we look at the brain tissue after a person passes away. And this is the same as with any of the neurodegenerative diseases. The definitive diagnosis can only be made after death. What we've learned about CTE is that it has this unique pattern that we see in the brain, particular protein tau that accumulates around blood vessels in the front of the brain. And we've seen that tau accumulation is related to cognitive symptoms like memory problems, executive function problems, problem solving, things like that, as well as some behavioral changes, impulsiveness, short fuse. And we see that it tends to be progressive, so it gets worse over time.
Do you think this condition is probably lethal enough to result in the death of people affected?
Yeah, so we have seen cases where people die with end stage dementia, and the pathology when we look at their brain is severe, and they don't have other reasons that they pass away. So So I do think that it is possible to lead to end-stage dementia and the kind of comorbidities and death that come with that.
Yes, so I think this is a cross-sectional study, right? And the brain that you mentioned have already been kept in the bank. So what did you do to the brain, and what kind of procedures, what kind of tests were conducted?
We have two arms to our study. We have the examination of the brains, where this is a traditional approach that we do in neurodegenerative diseases, where we slice the tissue and stain with certain antibodies to look for protein accumulation. Most importantly, here the tau protein, and then simultaneously we speak with family members of the deceased and ask questions about their thinking, memory, mood, behavior, as well as their exposure to repetitive head impacts in life. And then we look at the relationship between what the information we collect from the family members and the neuropathological examination.
So for you, why do you think this study is important?
So to date, we have case reports of CTE in elite hockey players, but we haven't shown this formal relationship. And showing this dose response relationship, the more you play, the more you're at risk for this disease, is really important for establishing causal relationships. It's also important clinically for advising families and players about their risk as they play more and more. It's also important for diagnosis. So among individuals who played a lot and who are now having symptoms years later, how much one plays can tell us about the likelihood of the underlying pathology.
So I'm curious to know, do you like ice hockey yourself?
Um, I grew up in Baltimore, which I think it did have a minor league hockey team. I'm not a big hockey fan, but I work at Boston University. We have a hockey team. I went to Cornell University as an undergrad. We also had a hockey team. So I've had some exposure to it.
Okay, so let's talk about the results. I think you have quite a number of them, but where I would like us to take this is what really surprised you the most in your findings?
I think what surprised me was how clear the relationship was. So I said that we only had enough players to do this study now, but the study is not an overwhelmingly large study. We had 77 brain donors whose primary sport was ice hockey. So the only way we could establish such a relationship is if the relationship was pretty strong, because statistically the stronger the relationship, the fewer number of participants you need in order to show a relationship. So I think I was struck by the strength of the relationship. And then I was also struck by, a piece of the study was looking at the enforcers. So these are the folks who, they don't have a formal position of fighting, but they tend to fight more than the other players. And we weren't sure how much the fighting contributed to this disease among hockey players. And while we did see that enforcer status was related to CTE, we saw that the relationship was largely driven by the fact that the enforcers tended to be elite players who played at very high levels. So after we accounted for how long they played, we did not see that the relationship between enforcer status and CTE was significant. It still was a pretty big effect size, so about twice as likely, even though that wasn't statistically significant. So I think that enforcer status is probably contributing, but this is a risk factor for all hockey players who play long enough. And it's really these years of play that seem to be really important.
So let's talk about the specifics around the relationship. So what does relationship look like at the moment before we talk about the implications?
Right. So what we saw was that the odds of CTE increased by about 34% for each additional year played. We also saw relationships between years of play and a cumulative measure of tau pathology. And then we also showed relationships between the amount of tau pathology and some clinical outcomes. dementia, and a scale of activities of daily living. Importantly, the folks who are in our brain bank are not representative of the general population of ice hockey players. So the donors to our brain bank tend to be elite players, so they play more than the general population of hockey players. So for instance, the vast majority of ice hockey players only play in the youth or high school level. The majority of ice hockey players in our brain bank are professionals. So we have representation across that whole range of exposure from youth to professional, but the fraction is different. And then most of the folks in our brain bank are also symptomatic. Their families are concerned about them. They wanted to know what was going on. So both of those things increase the rate, the frequency of CTE in the brain bank. So because of that, we can't say that what the absolute probability is of getting CTE for a given amount of play. We only know that there's this relative relationship. With each additional year of play, the risk increases.
Then what about seasons that these individuals actually played ice hockey? Do you think there has been some changes in how the game is played, changes in how the technology that protect players against severe injuries, or some policies, some differences, some changes over the years in how ice hockey is being played and regulated, or players are protected, could have had impact on City at the moment?
Yeah, no, I mean, it's a good question. Sports in general change over time, including ice hockey. I think there is less fighting than there used to be, which I think is a good thing. Hockey, unlike American football, the impacts are really happening mostly during games, not during practice. And then there have been changes in terms of when checking happens and at what age. So I think that those are differences that have happened over time. That being said, outside of the professional levels, the amount of play that happens for the junior players and the college players is different, is perhaps more. Instead of just playing a season, they might be playing year round. So I think those differences are complex and probably related to this outcome. But I think this is a good start for showing the relationship between the amount of play and risk.
So, how would you describe the current toolkit for assessing the risk of CTE in currently playing current ice hockey players?
So I think it's important to remember that this is a neurodegenerative disease that while it may start at the time of all of those impacts, we've seen cases in our brain bank as young as 20 or even late teens. Most of the time, the symptoms and the progression of the disease is happening years after. So there is this delay between the impacts and the symptoms. Um, I think what's important about this study and what's going on, what's important to tell current players is that the more that they play, the more they are at risk. And making decisions about when it's good to continue and when it might be good to stop is what I hope the information from this study can help with.
Do you think studies like yours potentially impact the future of contact sports like ice hockey?
Right. So you look at things like high school football in the United States, and there has been a decrease for several years in terms of kids playing tackle football at the high school level, but more recently it started to increase again. And the popularity of the NFL is as popular or more popular than it has ever been. So I'm not sure that these results will impact popularity. My goal is to understand these relationships well enough that we can communicate this information to the public, to players, to families, to parents, to folks affected with these symptoms, and for them to make informed decisions about their play, or for us to understand how best to diagnose and treat them.
So I'm questioning, what would you like to see happen based on the study's results?
So what I want is for people to understand that it's not so much about the symptomatic concussions, right? We've really seen that it's about this accumulation of impacts, thousands of impacts over a sports career, and understanding that it's these repeated impacts. We think years of play is a proxy for those impacts, and that the way we reduce the risk of CTE is by reducing those repeated impacts. So if we, with American football, it's really inherent to the game. So it's hard to take away the contact. But in a lot of other sports, including ice hockey, the checking, the impacts aren't as part and parcel of the game. The women play without checking. Kids play without checking. Adult leagues play without checking. So I think that recognizing how we can change sports to make them safer but still play is really valuable.
Let's look at addressing this issue and mitigating this risk from innovation and a policy perspective. What can still be done? I know you've mentioned the fact that we now have minimal impact in ice hockey compared to before. What changes do you still think can make a lot of positive change in improving how the game is still being played?
So I think policies that change impacts. So choosing an older age so that when checking begins, or not playing with checking at all. I think that is the first and foremost thing that can be done. You may have been getting at technology and whether there's helmets or something that can make a difference. We've shown in football that it's not just how many impacts, but also how hard those impacts are. Perhaps, there could be technology that reduces the force of the impact and thus reduces risk. What we do know is that it's very much about rotational injury and not so much about direct force onto the skull or something like that. So I'm less optimistic that technology will solve this problem. I think it's things like policy and changing how we play the sport that will be the best.
That's interesting. And so what's next for you in this line of research? What are you still doing? What is the next step?
Well, specifically related to hockey, I think we can do better than just years of play. There's a lot of variation in terms of position, how long an individual plays for a given season, how many games, what level they're playing. So I think our prognostication can improve beyond what we've done thus far. I think another important point, not directly related to hockey, is being able to diagnose this disease in life. We diagnose Alzheimer's disease in life. We diagnose other neurodegenerative diseases in life, not with absolute certainty, but with growing certainty. And we have really good biomarkers in Alzheimer's disease, but even without biomarkers, we've diagnosed these diseases for many, many years with some level of uncertainty, but we still do it. So I'd like to get to that place with CTE too. I don't think there's something inherently different about CTE and making diagnoses in life. So, we don't want to make a diagnosis that's wrong or that's inaccurate, but naming something is important so that we can identify therapies and see how people do over time. Also, providing the psychoeducation related to these diagnoses I've found in my clinic is really useful.
Yeah, I'm curious to know, as a professional, do you think if someone has early stage CTE, it could have been treated and prevented? Or do you think once CTE sets in, there is no hope, there is no intervention for that patient?
So I think there is a lot of hope, right? So even though we might not have a disease modifying drug, we have a lot of things to treat symptoms. We have a lot of drugs to treat depression, anxiety, irritability. We have a lot of non-pharmacological treatments and resources to offer families and patients. We also have seen that this is generally a slowly progressive disease. My expectation, we don't completely have the data right now, is that it's slower than the progression is slower than Alzheimer's disease. So I think there is a lot of hope. And I think talking openly about what to expect and what not to expect, and that folks can still live really productive lives and still contribute and have happiness in the setting of this is really valuable.
As a neurologic expert, there is this issue that I also want your thoughts on, which is when you were talking about talking more openly about these conditions. And if you look at what happened during the COVID pandemic, we had a lot of attention focused on infectious disease screening and vaccination rollout. Now we open the chapter of long COVID, and I think neurologic manifestations are some of the extensively documented and reported impact of long COVID. But we seem to have moved on, leaving people that have those kinds of symptoms, especially the neurologic manifestations, to continue to be probably in the dark whether they have that condition or not, or blaming or attributing that symptoms that they are having to something entirely different from that, even though it originated from COVID and an infectious disease harm that we may say is more popular than neurologic conditions. So as an expert, when you hear these kinds of relationships, when you hear this lack of attention to neurologic conditions, what are your thoughts on these? And are there opportunities that are currently available to actually bring these issues to the mainstream so that people, no matter how few they are, that are affected with this, can also be able to access the kind of care that they need?
Right. So yeah, I mean, I think that I think there remains some stigma related to mental health and this idea that mental health is somehow different than neurological health. And we're talking about the brain regardless of whether we bucket it as mental health or neurological health. And a lot of the things that we traditionally consider mental health, depression, irritability, anxiety, part and parcel of a lot of these what we call neurological diseases. And I think if we talked more openly about these symptoms and how they are treatable, even if we can't get rid of them entirely, and how we can still have productive lives and happy lives in the setting of some of these symptoms, I think that would go a long way.
What are you optimistic about in the evolution of neurology as a discipline?
A lot of physicians, at least when I was training, were reluctant to go into neurology because there weren't a lot of treatments. And I think that has changed over time. In the neurodegenerative space, we have new disease modifying drugs for Alzheimer's disease. I'm optimistic that this path will continue and that we'll have more things for patients. But I think that even in the absence of these disease modifying drugs, there's still a lot that we have to offer.
What do you still consider to be knowledge gaps that exist in further understanding the neurologic impact of contact sports in general?
Right. So we've sort of characterized these relationships for American football, for ice hockey, but we see increased risks of neurodegenerative disease, dementia among professional soccer players in rugby. So there's definitely other sports to explore in the same way that we have for American football and ice hockey. A big piece of this is diagnosis in life and developing biomarkers. And when we can diagnose better, we can also develop therapies. So I think all of those are places where we will go into the future.
Yeah, awesome. What are your last thoughts for me? Any last remarks for me?
I think that there is a lot of hope in this space, and I think that talking about these issues rather than ignoring them or talking about the fact that when we talk about them, it leads to more problems rather than fewer problems. It leads to suicide or something like that. There's been stigma around cancer, a lot around neurodegenerative disease in the past. And we've moved to talking about it more, making diagnoses, coming up with therapies, but not ignoring these issues. And I think that should be the same here. So that's kind of a hope for the future.
Wow, right on the dot. Thank you so much. I really enjoyed this. Thank you so much, and enjoy the rest of your day.